I just threw a lot of information at you. I know this is a lot. I know this is scary. I'm an interventional pain doctor. Half of my conversations, if not more, are describing procedures and injections. And I realized it's not a big deal to me. I've done thousands of epidurals at this point. But for that patient, it's very new, it's very scary. And I never want to take that away from a patient. I'd rather have this mindset than the patient say, oh no, I'm good. I can do that. I'm not worried. Let's do this. I'd rather have that patient-centric focus where I think that patient doesn't know anything, is maybe a little worried or scared. And I want to make them feel, hey, it's okay to feel that way.
Today's guest is really redefining pain management. She's a double board certified interventional pain physician who has trained at MD Anderson. With a resume that spans groundbreaking research, top-tier publications, and national conference stages, she has worked from spinal cord stimulation to cutting-edge, minimally invasive procedures. So please welcome Dr. Chopra to the MedStory podcast. Welcome.
Thank you so much for having me.
So let's start off by telling me what percentage of the patients that you see are in pain?
I'd be hard-pressed to say I have even one patient who I don't see. That is in very, very rare. Let's put it that way.
Okay. So when a patient comes to you that's in pain and scared, how do you help them feel heard or calm their fears?
That's a great question. So, I realized pretty early on, to take a step back. I think I saw something somewhere along, I can't remember exactly. Maybe it was some intro orientation to training or something that was going viral or whatnot, but it really resonated with me even till this day. I saw, somebody somebody vacationing in a different country who didn't, obviously English wasn't the native language of that country. And I saw it in reversal from their eyes and how it felt to be. I mean, if you look at medical terminology, for example, yes, we're speaking English, but medical terminology may as well be a different language, right? What we think is so basic. I mean, I know you also have a background in healthcare, and so do I. And it often we've been doing this day in, day out for years, that what's basic to us really doesn't translate to basic for the patient. So keeping that in mind, I try to, with every patient, kind of think about really, how can I break this down very simply to somebody who has zero experience or zero background, everything, don't assume anything, think everything is novel. And that way, I make sure that my evaluation, the way I'm explaining things, everything is comprehensive. And I feel like that in itself is a big factor that I've noticed that allows patients to feel more comfortable, where even just acknowledging, listen, I know this is a lot. I know I think it always ends up being every patient conversation I have, especially new patients, where I'm like, I just threw a lot of information at you. I know this is a lot. I know this is scary. I'm an interventional pain doctor. I am almost half of my conversations, if not more, are describing procedures and injections. And, I realized it's not a big deal to me. I've done thousands of epidurals at this point. But for that patient, it's very new, it's very scary. And I never want to take that away from a patient. I'd rather have this mindset than the patient say, oh no, I'm good. I can do that. I'm not worried. Let's do this. I'm in pain. But I'd rather not assume, I'd rather have that patient-centric focus where I think that patient doesn't know anything, is maybe a little worried or scared. And I want to make them feel, hey, it's okay to feel that way. And I've noticed that, they also, it helps them trust me, and trust, big thing. I mean, if I put myself in the patient's shoes, it takes a lot to discuss healthcare. And on top of that, go one step forward and have somebody do an injection or a minimally invasive procedure or anything, right? It takes trust. And I always want to make sure I tell patients, hey, thank you for trusting me. I appreciate it. I see you. So that's my long-winded answer.
I imagine that they really appreciate it when you thank them, because you're thanking them for putting their trust in you as a professional. And I want to acknowledge that your ability to sit down and try to put yourself into their shoes, I imagine, is so powerful for them. because you're right. They are coming suffering in pain and they're looking for a solution. And you have this huge toolkit of things that you can pull from to help get them to out of pain and where they want to be. But figuring out which is the best option and then communicating to that to them, like that is a maybe just as important of a skill as the procedure itself.
Absolutely. I always tell patients at some point, or even patients, or even I sometimes teach courses around the country at one of our pain societies and whatnot. And I always tell patients or residents or medical students, anybody coming by, that, you could ultimately teach a monkey to do this. Teach somebody enough times, it's mechanical, it's step by step. But really, what sets you apart as a physician is you sitting down, you being human with that patient, you showing them, hey, let's bring the model out. My motto really, it's pretty simple. I consider the golden rule of medicine as a healthcare provider, but it really is, treat these patients, treat every single patient that walks into your practice, your clinic, as you would want your mom or dad or a family member to be treated. And I think that's the golden rule. And if you utilize that with every patient encounter, you're doing the right thing. You can go to bed at night knowing, hey, I did my best.
I I agree with that rule and I try to apply it myself in my own practice. I find that one of the challenges as healthcare providers is that we want to treat all of our patients as if they were family, but at the same time, we don't want to bring home the burden of someone in chronic pain home with us. So it ends up affecting our personal life. I imagine that's a challenge, especially for a physiatrist like you.
Yeah, you bring up a really good point, and I think, that is something that most people don't really realize, the other side of this specialty, right? Where to some extent, I'll be honest, I mean, it's impossible to be fully able to do that and fully, I mean, we are human, right? If something happens, I definitely will be up at night in certain cases thinking, hey, did I do the right thing? Did I offer this patient the right thing? Could I have done something slightly different and have a different outcome? I mean, that's what makes medicine, regardless of the specialty, right? That's always going through any healthcare provider's mind, right? So I definitely have moments of that, but for the most part, I try to focus on, you know, I did what I could in that moment. I try, you know, I if I were to look back, maybe I could have done things differently. And that's what makes medicine an art sometimes more than a science.
Absolutely, for sure. It's always going to be the combination of the art and the science, and we need to be okay with that. It's never going to be exact. So I want to dive in a little bit closer to probably something that I'm guessing you deal with quite frequently, and that is with diagnostic imaging. Um, I have found that a lot of patients will review their imaging maybe even before they see the doctor. So they'll go get their x ray or their MRI, and then they'll see the report on their portal. And if you're not a healthcare provider and you read a diagnostic report, it's scary as hell. So when they come in there being like probably dreading talking to you because they think they're dying, how do you handle that situation?
So I always say, listen, let's take a step back. Let's go. Let's break this down. Okay. Let's go line by line. Let's talk about it. Just because it's this fancy, complicated word, I bring out the honestly, I make it, I'm a very simplistic person. I'm a visual person. I like to just break it down and I bring out my spine model and I'm like, listen, this fancy statement that you're seeing at L3, L4, for example, like just protrusion, spondylolisthesis. I'm just throwing out like some of this complicated words that could be complicated to some people. And I'm just showing them, hey, this is just a fancy word for meaning this. So what is the outcome really? Not much, is there's no instability. Those are the things that would be worrisome. So I kind of explain it to patients because I think patient education really is a big part of all of this to help kind of calm their fears. And I try to think of it, I'm like, I get it. Once again, I'm going to say, listen, I get it. If I were in your shoes and I don't know what this is for a lot of industries, actually, so I can relate, if it's not medicine, a lot of this stuff goes over my head, right? So I'm like, okay, break it down. I don't know what this means. This is freaking me out. So I do relate to patients and I tell them that. And I think I've noticed that that helps because once again, I'm showing them I'm human, you're human. Let's keep it simple.
Do you ever have experience where you will pull out maybe your anatomic model, but then you can see that the patient, it's still just not connecting?
I do occasionally notice that. And, I will, or I'll have them. And I found this tool to be very helpful, something I've learned over the years. And okay, let's take a step back. I know I've explained or I threw a lot at you. Tell me from what I've told you, what is it that you're getting? And then I can find gaps in this. And I'm like, okay, let's pause here. Let me go back. Let me bring out this fine model, or let's try this an animation that we can find on the, like on the internet or Google it. And then sometimes in different ways or different explanations really click with the patient.
Yeah, that is so smart to have them speak it back to you, because if they can explain it to you, then then you know that they understand. But if not, you say, okay, I've got to find a different way to communicate it. And this is where I've actually become kind of obsessed with the idea of storytelling, because what I've found is that you can communicate the anatomical model and some people will understand, but other times they just want to know that you've treated something or someone that's been going through something similar and helped them get that desired outcome. Is there ever times where you can kind of pull from certain patient stories and help them feel at peace?
Absolutely. Especially with injections where, I've gotten I can't even, I mean, at least once a week, I'd have to say, I'll have patients and I'm like, I'll take it as a compliment, but they'll say, how
Okay,
long have you been
I'll
doing this?
repeat
You
the
don't look
question.
that
Is that okay?
old. So I'm like, I promise I'm older than I
Yeah.
look.
Okay.
I've done
Um,
about 10,000
so
epidurals. Usually, I
I
mean, that's
find
my bread
that
and
sometimes
butter
when
injections,
patients
but
don't
whatever it is,
understand the
it's
anatomical
definitely in the
model, that
thousands for
one of the
most of
best
these
ways is
injections now.
actually to
So I'll
help them
explain to
and
them,
tell a
listen, I've
story
had
of maybe
numerous
a
patients
similar
with
patient, of course, without giving any
your low back
identifying
pain
information,
radiating
but
down
letting
your
them
leg,
know that
the
you've
numbness, the
treated this
tingling,
condition
all of
before
this,
and you
sometimes they'll
can
be like,
help
it
them
feels
get
like
out of
there's a
pain.
knife
Is there times
poking
where
and
you've pulled
jabbing
from
at me
past
or
experiences
burning
to
or
help put
like
the
my
patient at
legs
ease?
are on fire. And I'm like, I get it. It sounds crazy. And I know you're self potentially doubting yourself and your symptoms, but all of this makes sense. And I've seen multiple patients with this and we've been able to treat this. So let's, I was like, I appreciate you for trusting me and being patient with me, but let's try to get you there as best as we can. So I do tell patients that, just because, for example, your MRI is normal, your X-ray is normal, the MRI isn't the end all be all. At the end of the day, this is something I commonly tell patients that I'm not treating your MRI. I'm treating you. You are the patient, not the MRI. So, you can have what I like to say is, I could have the same MRI as you. And if they do have pathology or, disc protrusions and whatnot, like I could have the same thing or pull out a couple other people randomly in our age group or your age group. They may have that too. But if they're not having pain, there's nothing necessarily to treat, right? Like you don't go after, don't fix what's not broken, right? In that sense. So the other
So
side of
then
it
how do you
is if there's a
handle the
completely
patient that
normal
comes in
MRI, in
and
those
maybe their
cases,
scan
then
looks
maybe it's not a nerve,
fine or
maybe it's
normal,
not a
but they're
disc
still
bulge or a
in
nerve
pain?
impingement.
How do you
Maybe
handle those
it's
kind of
not,
patients?
but that's just one piece of the puzzle. That's what I tell them. It's like I'm playing Clue. This is medical Clue. MRI helped me. The history, the physical examination, the MRI, X-rays, all of that are pieces of the puzzle. So, for example, if there's a muscle spasm or a muscle sprain, myofascial pain, that should be a normal MRI. I mean, if it's not secondary to something else, right? But that's not to say, I mean, I don't know if you've ever had a muscle spasm, worst, probably a really high up there, at least 8 out of 10. It can, when you feel that spasm, you're going to feel it. And I always tell patients, listen, just because it's a clean MRI, that's not, I'm not taking that away from you. That doesn't mean you're not in pain. You can still be in very severe pain. It's just not pain related to a disc bulge or a pinched nerve or whatnot, something that the MRI is sensitive to picking up, right? There's other types of pains. And and I think that makes patients feel heard and seen that, hey, I'm not making this up. I'm not crazy. And I make sure to let them know that because I do think it's important. So if there's like can you give me an example specifically? Like is
Of course. So if you're going through a comprehensive exam and you're not finding any positive indicators that are pointing towards a biomechanical cause of their pain. However, they are still in almost an unmatched level of pain, then what kind of things would you like to communicate to them? And like, what kind of referrals would you make for something like that?
I think that's a great question. So there, I definitely there's a component when you think of chronic pain specifically. If you think about, I don't know how you are, but if I had the flu or a pretty bad viral illness, I feel like I'm dying. I'll be honest. I'm like, don't talk to me. I feel absolutely miserable. And so that's like a couple of days, right? For most people, they recoup within a few days to a week. Imagine 6 months plus. That's theoretically the technical term for chronic pain, right? Dealing with this for most patients I see for years, right? I mean, if you're gonna tell me that doesn't seep into every other aspect of your life, I find that very, very hard to believe, right? And so, you know, there are other components. So it depends. I mean, ideally, when I talk to other physicians, potential referring providers, I always say, listen, if there's pain and there's causes for pain, and you started the sooner they get to a pain doctor, the better to see the underlying diagnosis, the etiology, what's causing the pain. And if not, I mean, there is also a very, very high incidence in my patient population of depression, anxiety, up to 50%. So I like to tell patients, listen, I'm not discrediting your pain. I can imagine you are in pain, that I'm not taking that away from you. But, you've been dealing with this for so long where this is clearly affecting, so many aspects of your life. The way I see it is we have this problem. Let's kind of attack it from multiple ways, get all the right people on board to get you the best relief and the best treatment and optimize patient care for you the best way we can. Let's utilize all of our resources. And, sometimes a pain psychologist goes a long way in our patient population, psychiatry. So those are, we work very closely together in order to optimize patient care for these patients.
That's cool. So you guys actually will work with a psychiatrist or a performance psychologist to kind of help you're making sure you're getting both ends of the spectrum.
Absolutely, because if you look at it, if you have this problem and I'm doing everything potentially that I can do, but there's this, well, even if there is a pain diagnosis and there is an actual pain etiology for the pain, if there's all of this other stuff, we all know, other diagnoses such as depression, anxiety, and others, that is only inflating, it's exacerbating their pain, right? Pain is a symptom as well. So in those cases, I can try to be an exemplary pain physician, but there's only so much I can do until all of this other stuff isn't also concomitantly taken care of.
Yeah, I agree 100%. And I think that's something when I'm explaining to patients is they have to understand that the pain experience is very much multifactorial. Yes, is there a biomechanical etiology? A lot of times, yes, there is. But if we're not looking at your sleep, if we're not looking at your anxiety, your depression, your socioeconomic status, all of these other factors that are also going to play into your pain experience, then we're not really justifying our role as a provider for these patients.
Absolutely. And I feel like with that PM&R background, in addition to the musculoskeletal, it's very comprehensive. And I feel like that helps. I often, you brought up a good point, pain, family issues. And that's when I'll realize, okay, sleep, let's get the right people on board to help optimize this because there's only so much I can do from one aspect, but let's get different people focusing on different aspects to help kind of synergistically help this patient and their pain.
Okay, I gotcha. So let's dive into how we can help people avoid surgery. And let's role play right now because me, for example, I'm actually currently going through a bout of low back pain with lower extremity radiculopathy. Now, for a lot of people, pretend that I don't know what's going on and I am scared. What is the first step that I should do if I am experiencing this pain?
So this is my favorite topic. I love talking about all things avoiding surgery because my motto is really, let's get the most mileage for the parts you do have, at least unless if we can't do that, then obviously we're gonna proceed and have our surgeon friends on board to help. But I think a lot of patients don't understand is let's get there's the least invasive to more invasive paradigm that we follow. And, if you're a patient that's depending on, let's do a comprehensive physical examination, full evaluation, and let's talk about, what type of pain you have. How long has it been going on for? How constant is it? Is it affecting your sleep? Is it affecting your job? Is it affecting your personal relationships and whatnot? And, there's a lot of, initially I like to get patients, I try to understand and listen and see what is the type of pain. Is it nerve pain, neuropathic pain, myofascial, muscle related pain? Is it a sprain overall? Is it a disc protrusion, which can be causing nerve impingement? So those are all of the things that I'm looking for. And once I get my buzzwords, I like to link each, the type of pain to, well, let's try to get you on a muscle spasm, like some kind of medication to help with your muscle spasms. Let's get you on a neuropathic medication to help potentially with your nerve pain. So those are the types of things I like to do. I'm a huge proponent, and I think you agree with this with your background with, let's get you into physical therapy. Let's do that rehab. Let's do this. Let's start this multimodal pain regimen with rehab as quickly as we can. And then let's have you come back. Let's get, if we need to get imaging, let's do our imaging. Let's figure out what's going on, and let's deep dive into what is the underlying etiology. Is that myofascial secondary to a disc protrusion causing a radiculopathy, for example? So I like to look at, I like to really just break it down and let patients know, listen, we're gonna get you to a level. We're gonna try our best. We're gonna do everything we can for you to get you out of this pain, or at least make the pain more tolerable for you.
Yeah, I like that. I like to use the framework of it's kind of like a staircase, being the bottom stairs are the most conservative to once you get to the top of the stairs, that's surgery. Now, there is a couple challenges with this. Number one is that when you're suffering, you want to get out of pain as quickly as possible. And when you tell someone, I want you to go to physical therapy for 6 weeks and then come back and see if you're out of pain, do you find that they may not fully buy into that because they want relief sooner?
Absolutely. And, the way I tell patients is, we're going to do what we can and we're going to get you on the right medication. But ultimately, I do want to get, I do think there's a role and a component of medication management, for example, for rehab. And so let's do it like synergistically, because even if I can get you out of this pain, odds are most patients are more chronic as opposed to acute, right? So they do have, functional decline. They do have, atrophy, for example, things that they wouldn't realize or we'll kind of pinpoint. And I do have patients who are reluctant and be like, oh, I did PT after my shoulder surgery and it didn't work. I'm like, okay, well, that was probably post-op recovery. It's completely different goals, completely different objectives into what the purpose of that therapy is, right? Versus this is not your back, right? This isn't post-op PT, right? So we're trying, the focus is a little bit different. They're going to be focusing on, creating a home exercise program. They're going to be focusing on strengthening and, stretching those muscles that are all contributing to it. For example, if they have knee pain, I mean, a big thing that we both emphasize on is let's get that quadricep strength. Let's strengthen that quadricep to help. So the way I tell patients is, let's start this multimodal regimen and treatment plan. Let's start with the basics. We can do injections, but for example, if it's a knee problem, I'm telling that I can do a knee injection. That's not hard for me. But let's get you we have to create a maintenance program. So that way you don't have to, I can only do so many of these and it's to what extent is it beneficial for you to go through. But you got to develop that daily maintenance program where you're working on this yourself too. It takes both pieces of the puzzle. And I even go as far as to tell them, listen, I'm trying to do these injections to get that pain better so you can participate even more in physical therapy. That is one of the goals that I have in mind, right? So I really emphasize, and that also is a little bit of patient education where, I'll say maybe I'm exaggerating a little bit, but just to get this point across, you can look at your, that example of post-op, even for back pain, right? If it was the same type of condition, where it's low back pain, previously had surgery, PT didn't work for me, doc. But I'm like, it's so different that it's like you telling me that, my knee hurts, but I had PT for my shoulder. So they're apples and oranges. It's not going to work, right? So I'm like, I need, I get and I want them to feel seen. I'm going to tell them, listen, I understand where you're coming from, and I'm not taking that away from you. But I try to go back and explain the whole model, and this is my approach. This is how I do things, because nobody likes injections, right? I'm sure you don't want to be here like often. You want to minimize that. So this is your part. You doing your part in this, and I'm going to do my part.
What about setting expectations for that chronic pain patient who has the goal of being pain-free, even though you and I might realize that that is probably not realistic?
That's a great question. It's a great point you made. So I like to tell patients from the get-go that, really the purpose is I'm trying to reduce this pain to make it tolerable for you. If I could get rid of it completely, fantastic, right? But sometimes that's not possible. But at least, we can hopefully bring it down to a tolerable level.
For sure. One thing that I like to ask them is saying, okay, your pain's here. What if we were to be able to get your pain to a certain level where you'd be like happy with that? What level would that be? And oftentimes they'll say, you know what? I'd be happy with a 2 over 3. And I say, okay, perfect. So let's make it so that you can tolerate this activity at that 2 or 3 level. That's our goal together. Yeah. And then,
Absolutely. And I'll also, especially after, like, for example, if I've done an injection and they're like, no, I'm still in a lot of pain. It's a 9 out of 10. It was a 12 or 100 out of 10. Now, but it's still there, right? And I'm like, okay, so we didn't get that much relief. Tell me more, right? Or have you noticed that pain wise, it didn't help you, but have you noticed other things? Like, are you able to do something that you weren't previously able to do because of the pain? And they'll take a second and they'll be like, I've been able to walk better. I've been able to, for the first time, straighten my back. Oh, I've been able to hold my grandchildren. And I'm like, well, isn't that a huge quality of life indicator, right? Like, it's not just pain. I always tell patients, I'm not just a pain doctor. I'm also like quality of life, functionality. That's just as important to me as just pain improvement. And so those are little things that I always want patients to be cognizant of.
I agree 100%. We don't measure progress only on pain reduction, but also functional improvements. Now, I want to know, because you actually told me that you are an independent contractor doctor for a bigger group. Now, what part of you having to actually go out and market yourself to progress yourself in your career as a physician have you had to do?
So, I've been fortunate where I've worked with bigger companies, which makes it easier for marketing from that perspective. I'm trying to, more from a personal level, I mean, I realize how passionate I am about patient education and for patients to really be advocates for themselves. So I've kind of started this initiative. That's what I know we talked about this previously on Instagram is I'm just trying to definitely I'm having a little bit of fun while I'm doing it. You'll see my silly side a little bit on Instagram. But, the message is I really want to get patients that basic information where they can be advocates for themselves. They don't need a family member or a friend in healthcare, or, they know the bare minimum basics that we would take for granted and be like, well, yeah, that's common knowledge. No, it's not. Nothing is considered common knowledge. There's no like bad question, for example, right? So like I am using my platform right now with marketing, I guess, but more so for patients to know, like, what are red flags with back pain? If they have, loss of bowel or bladder, having accidents, that could be a surgical emergency. That's something you ought to quickly talk to your doctor to get to a spine surgeon for. If it's, for example, back pain with numbness and tingling, sharp shooting pain down their legs, that's probably not just a sprain. That's probably some kind of a pinched nerve in your back. Go talk to your doctor, and then in addition for providers or potential referring, like primary doctors or potential referring providers to myself, I've had conversations and talks with them where I'm like, we don't have to always just give opioids or pain medication, we can, it's very cumbersome for patients too. I don't know about you, but I realized that if I'm preaching to patients, hey, have compliance with your medications, I had to set an alarm to just for my Z-Pak. I'm like, this one pill a day for 5 days is I'm having problems with compliance with that. That I'm like, you know, let's get an injection. Let's do it so you're not on the daily regimen of medication. I mean, gabapentin is 3 times a day dosing. If that's not cumbersome, I don't know what is. On one aspect, I'm telling patients, hey, have that functionality. Let's get your quality of life back. But in my mind, that's like a kind of putting a patient on a leash for 3 times a day dosing, daily dosing.
I think it's important that you as a physician share these kind of stories and say you suffer and struggle too, and you're a human as well. And I think that that's going to only build trust that patients have with their doctor when they say, oh, you know what was once seen as this profession where they have to be perfect at all times and has led to actually a really toxic culture, to now it's kind of shifting to say, these are humans too, and we need to know that. Do you find that it's challenging for you to be a little bit goofy on Instagram because you feel like you're supposed to be perceived a certain way?
Absolutely. For the longest time, I was like, should I do this? Should I not? Like, do I really want to put myself out there? Because, I mean, you are kind of showing the world. I mean, I'm a pretty private person. So, I feel like I'm personable. When you talk to me one on one, I'm fine. But just putting my whole life on social media, like, I didn't grow up like in this day and age, I think if you're a little bit younger than me, you kind of grew up with, like we had MySpace, I think, but that was so like, I wasn't ready for that at that moment, and then Facebook kinda came along, I was late to that, so, for me, it is a little different versus I think if you ask somebody in this generation, they're like, "Well, yeah, why not? Like, why not?" That's what social media is, right? So, I definitely had initially and it's getting easier, let's put it that way, and I do think I have noticed that once I tell patients my personal I mean, whatever I'm telling you today, I just want to be fully transparent. These are the examples if any of my patients were to watch it, they're like, yeah, Dr. Chopra mentioned this to me last week. And I realized that makes you relatable. Like you said, that makes you human. They're able to tell you more once they feel like they can trust you and if you're more personal and you can connect with them. And to me, that helps me do my job better too. And I try to look at, I want patients to know they're not alone. Today I'm a doctor, tomorrow I can be a patient too, right? I've been a patient, right? So kind of putting myself in their shoes, and that's what I'd like to do because I just want patients to have a good experience the way I would want a good experience, right? So I really try to keep that at my core.
I have so much respect for you in that approach that you do, and always trying to remove yourself from your physician role and putting yourself in their shoes, which is a really hard thing to do when you're seeing so many patients a day, especially that are suffering with chronic pain. I think that people don't realize how hard the field of physiatry is, constantly dealing with that. So I have a lot of respect for you from being able to kind of set yourself apart and be human first, which is really amazing.
Oh, I really appreciate that. Thank you so much. And I feel like that's kind of what your platform is as well. I was very impressed, the message you're putting out there with the different providers. And, I was so excited to be invited to be a part of this.
Well, I'm so happy to have you on for sure. And hopefully, this is just the first of many. But if someone's listening to this and maybe is in pain or they just want to connect with another PM&R doctor, where is the best place to find you?
So, like I said, I am on Instagram, social media. You can contact our office. I can give those details as well. I have an email that I'll share with you that you can definitely forward to your audience as well. And, I'm like I said, I'm just really big on patient education, just bringing awareness. I think in this day and age, let's utilize social media. Let's utilize all these platforms, YouTube, these podcasts that you're doing. Let's utilize it to, for betterment. Let's get healthcare. Let's get it more mainstream. It can be a very convoluted system. So let's try to do I think as a physician or anybody in the healthcare space, it is really our moral duty to get that information out there to the, mainstream and to the average person, for example.
You're speaking my language, and it's exactly why I'm doing this, to get people like you on there, share your story, and hopefully through these stories and these little clinical pearls that we can help people feel more empowered and more make better decisions about their health. And that's what it comes down to. Dr. Chopra, thank you so much for coming on. You rock.
Thank you so much for having me.